Well, you're almost 80% of the way through, so I usually do a question and answer format to try to keep people awake because you actually have to pay attention enough to listen. We can tell if you're sleeping by how many people respond. So we're going to review some scenarios in pediatric respiratory illnesses and consider some differentials, diagnostic options, and treatment options as well. So question number one, a 6-month-old term infant born without complications, seen a routine visit for immunizations, alert, interactive, weight is 50th and length is 25th centiles, feeding well with occasional spit up, is gaining weight. Mother notices the noisy breathing, which she calls wheezing, since about two weeks of age. The wheezing had been louder a week ago when she had a cold and upper respiratory symptoms for a few days. The family history of asthma in both parents and 2 older siblings. The investigation you would consider at this point would be what? A, chest film, B, upper GI, C, chest CT, D, bronchoscopy, E, no investigations now. Okay, well, I mean, I think, yeah, you could do nothing. Actually, there are a lot of different potentially right answers here. The scenario, the way it was kind of presented, really is kind of low key. But the fact is that either the chest x-ray or the upper GI study would be preferable because as we'll talk about a little bit later in the scenario, this is a little bit more than just the wheezing with some feeding difficulties and feeding intolerance. And so stridor, or this wheezing that was in quotation marks there, is a definition as a harsh, coarse, grating sound with crowing quality. It's important to understand the phase of breathing, whether it's inspiratory, which usually reflects extrathoracic airway obstruction, expiratory, which is intrathoracic airway obstruction, or biphasic, which really indicates fixed and variable only in one phase with dynamic obstruction being there. And so this turbulent airflow can be seen with the extrathoracic airway obstruction. So normally you have a very low kind of intrathoracic negative pressure to breathe. But when you have an extrathoracic laryngeal obstruction, you have to generate a much more significant negative pressure, which causes the extrathoracic airway to involute and collapse, and causing the crowing noise during inspiratory phase. During exhalation, if you have extrathoracic laryngeal obstruction, what you have to do is you have to generate a much more positive pressure, and you can also, you actually bow the airway out. But often we will not see any significant extrathoracic or, expiratory phase of wheezing or crowing. So the causes of stridor in infancy are laryngomalacia, floppiness of the supraglottic structures, tracheomalacia, floppiness of the trachea, subglottic stenosis, airway lesions such as webs, cysts, and hemangiomas, vascular malformations, ring, sling anomaly, vocal cord paralysis, infections, and foreign body aspiration. So it's very, very wide, and obviously as the scenario will kind of fall out, you'll actually see that there's more information that's given. So the most common cause, however, of laryngomalacia is stridor, most common cause of stridor, and 60% is laryngomalacia isolated. So the cartilage in early infancy at this child is not as firm. There's collapsibility during inspiration normally. There's some prolapse of the epiglottis and arytenoids. And this is worsened by agitation in the supine position. So what you can see is that there's prolapse of the arytenoid cartilages here and curling of this epiglottis, which causes that crowing or the turbulent flow rather than having a normal larynx. And so you've got the prolapse and curling. It's a little bit redundant there. So the management is really close clinical observation, similar to what you all had wanted to do. Symptoms may worsen over the first few months, but improve usually by 12 to 18 months in most cases. So the barium swallow upper GI to screen for vascular anomalies, and this is what we as specialists tend to do because there's also do bronchoscopy and visualization of the airway may be indicated if this is a more significant symptom. If there's an atypical course or failure to thrive, bronchoscopy is absolutely indicated. And severe cases may require surgical intervention. So in terms of tracheomalacia, there's weakness of the tracheal walls and dynamic intrathoracic airway obstruction. The airway is always stented open during inspiration because of that negative pressure with the airways coursing through this through the chest cavity. the airways are pulled open during inspiratory phase, but they collapse during expiration and forceful exhalation, such as crying, and it's often worse after a bronchodilator treatment. So mild tracheomalacia may give some expiratory noise, where moderate to severe gives a biphasic noise. So there's primary tracheomalacia and then secondary causes, such as chronic inflammation from reflux or from positive pressure ventilation, such as preemies who've been in the NICU for a long time who have acquired tracheomalacia due to the positive pressure ventilation for a prolonged period of time. And so this is a picture of tracheomalacia that you can see the anterior lateral flattening of these cartilaginous rings and also prolapse of the posterior membranous segment. And this is, mild, really mild to moderate, but when you have somebody who's got biphasic crowing, it can be much more significant. And with airway fluoroscopy, as you can see here, during inspiratory phase, which is in panel A, you can see that the tracheal air column and lateral view is quite wide, whereas during expiratory phase, it's narrowed and almost obliterated. So what the scenario was getting at was, does a child who's wheezing, and I said wheezing in quotations, have vascular ring or sling? These cause fixed but pulsatile compression of the trachea in a variety of ways. The presentation is often of that with a chronic cough, inspiratory stridor or inspiratory transmitted sounds, and homophonous wheezing. The study of choice then is the barium esophagram, upper GI, or bronchoscopy. And the reason being is that why not go immediately to MRI? Because MRI with a child who has a narrowed or has airway compromise, perhaps on even a office visit, you have to do sedation and probably will have to intubate the child to go ahead and safely be able to do a procedure. A child that age can hold still for an hour or 45 minutes while the MRI is done. CT, of course, is much faster with current processors, but it also has a lot of radiation and much less with the upper GI. So these vascular compressive lesions, there are a couple that probably are more commonly talked about. This complete vascular ring encircles the trachea, which you also would need to kind of keep an eye on. One of the more common ones is this double aortic arch. So there's the persistence of instead of the ductus arteriosus, you've got this persistence of both embryologic aorta, and then which you have this the aberrant left subclavian artery. So this comes off instead of here, it comes off posteriorly. And with a pulmonary sling, the left pulmonary artery arises from the right pulmonary artery, coursing behind, and is not the main pulmonary artery, and compresses the right bronchus, and also can cause this. So the vascular compressive lesions should be considered in the differential if you're given a scenario like this on the test. And so the barium swallow can be very, very helpful here, so that you can see with the PA sling, there's posterior compression of the tracheal air column. And so what you also can find here is there's some dilatation of the esophagus that may also be able to be seen. One of the other lesions, especially those in former preemies who've been intubated for a long period of time, with acquired is usually more severe. It's usually, as I said, usually a result of endotracheal intubation. The presentation is that of often a barky, recurrent, croupy-like cough, but not croup. And the bronchoscopy is necessary for definitive diagnosis and to demonstrate the degree of narrowing. Management is based on the degree of stenosis, with clinical observation for somebody who has mild and has great growth, and anyway up to tracheotomy, and then cricoid split for somebody who's really having failure to thrive, and as demonstrated on bronchoscopic evaluation, to have severe subglottic stenosis. Subglottic stenosis, as you can see here, this being the normal larynx during inspiration here, and you can see the subglottic stenosis here present, and a little bit less so here. But these are very commonly found in some of the micronates who populate our pediatric clinics. Another thing somebody who's been instrumented at birth, or who's had a difficult birth with neck distraction, or who's had a prior cardiothoracic surgery, this can either be a congenital anomaly, but it can also be acquired, such as nerve injury, as I was alluding to. The obstruction is that of a weak cry, hoarseness, dysphagia, and aspiration. Again, one can do a flexible bronchoscopy or endoscopy at bedside. Nasopharyngoscopy alone may be all that's necessary. And it could also be a side effect of some neurologic conditions, such as Arnold-Chiari, birth trauma, et cetera. And the management is really that to maintain an adequate airway. And unilateral paralysis usually or rarely requires treatment, whereas the bilateral paralysis often needs to have a surgical airway placed so the child can go ahead and continue to grow and then subsequently have a more safe ENT procedure. And so what you can see here in this picture is that this is again normal larynx, and this is normal larynx with the vocal cords abducted and then vocal cords adducted. And what happens with unilateral vocal cord paralysis is the cord can't move out of the median, and with bilateral vocal cord paralysis, neither cord can move out of the median. And this is why tracheostomy is often something that's needed for this. And if there's nerve damage or other neurologic injury perhaps, then this can become a life-threatening injury. I put a table in here, which I'm not going to go through now, just about the key findings. It'd probably be worthwhile reviewing because I think it's kind of gives you some bullet points to go look at for some of these airway lesions we talked about. So question number 2, a 2-year-old boy is brought to the ED at midnight with difficulty breathing and respiratory distress. Multiple sick contacts at home. He's had a nasal discharge for about 3 days, appears anxious, tired, and toxic. He's febrile to 104, heart rate is 105, respiration is 40 per minute. His pulse oximetry is 93% on face mask at 6 liters per minute. Chest X-ray shows a ragged appearance of the tracheal air column. So your first step of the management in this patient is to do what? A, get a lateral X-ray of the neck, order a chest CT with contrast, plan urgent bronchoscopy, intubate in a controlled manner, or obtain a stat arterial blood gas. Okay, great. Most of you got this, so, or at least half did. Intubate in a controlled manner really is the correct answer. The reason being is that respiratory distress in a febrile tachypneic child with stridor, there's differentials the same, but really this indicates the greater likelihood of either epiglottitis or bacterial tracheitis. And both of these are life-threatening issues which should require very controlled management of the airway in an operative setting or emergency department setting where you have anesthesia available. The epiglottitis is most often due to H-flu type B, but now with H-flu Hib immunizations can be due to a panoply of organisms, particularly in immunocompromised kids. Other etiologies are listed. The classic is a muffled or hot voice, the respiratory distress, and the child, as I said, is appearing toxic. And I think toxic is kind of the differential between croup and a bacterial tracheitis or epiglottitis for you. And as I said, the child in a tripod posture with dysphagia and drooling is a classic scenario put on board questions for a true medical emergency, that being either epiglottitis or bacterial tracheitis. The best things to do to keep the patient calm, avoid agitation, which will increase the work of breathing and control the airway in a stabilized fashion. So the normal epiglottis, epiglottis and glottis, and this is the swollen, inflamed, beefy red epiglottis. So you can imagine that this is going to be an incredibly difficult airway for a child to maintain, especially a febrile child, to be able to maintain patency as time goes out. So croup, viral laryngotracheal bronchitis, the viral etiologies are known to all of you. It causes airway edema of the larynx subglottis. There's marked narrowing and a barky seal-like cough. This often increases at night because the diurnal endogenous corticosteroid production is lowest at 3 to 4 a.m. So just like asthma, it always gets worse in the middle of the night. The problem, and it also responds to adrenergic agonists and to steroids. So it's not uncommon in my practice to see people who've had diagnosed, and this often gets by what I call EMR perseveration. Somebody's labeled as having croup, and then every time they have a croupy cough from then on, they're croup. And people don't just have 8 episodes of croup and have a normal airway, okay? They likely have asthma, and the medications you're giving for an acute episode of croup in an ED urgent care setting also treat asthma as well. And you really have to kind of take a very careful history to try to differentiate the two. So the therapies, as you know, are racemic epinephrine, steroids, either oral or IM, and in some cases inhaled budesonide may be helpful. Everybody talks about this, and I've seen this in the past on board's question in terms of a steeple sign. I give that to you because it may be presented. They would have to give you a very classic picture of that. Clinically, I don't see it very often, quite honestly, because it's very hard to place a child who almost invariably has to be placed in a recumbent position while getting an x-ray who's already in respiratory distress. There's really not a point to going in and doing it because usually you're mobilizing therapies already. So you're demonstrating something which you're already kind of giving therapies case for. So I seldom see this in my practice. So bacterial tracheitis was the other major differential for this child here. It's often in a child who's had croup for several days. Staph, a direct bacterial infection of the tracheomucosa. The child, as I said, has a toxic appearance. And I'm not going to do endoscopy under this unless the airway is in place, but if one would do endoscopy, you have a thick mucopurulent discharge with slough epithelium and a sheet-like pseudomembrane, which occludes the trachea and can occlude the entire tracheal column. And this is something which really needs debridement on a recurrent basis here. So you secure the airway and start antibiotic therapy, you do airway hygiene, and if you get early enough in the course, by identifying it, you most often have complete recovery. So what about foreign bodies? So just a note, if you have a foreign body scenario in any of the questions here, the airway has almost a equal bifurcation up until about a year of age, so there's not really a right-sided predilection in foreign bodies until after about a year of age. After that, there's a more acute takeoff to the left main stem bronchus, and most of your foreign bodies, 2/3, are going to be on the right side after a year of age. So what you see is asymmetric hyperinflation of the right lung. So right main stem foreign bodies with lateral decubitus views, what you see is that with left lateral decube, the heart goes down over here, and you actually have some hyperinflation on the right side. With the right lateral decubitus view, with air trapping here, the cardiothomic structures do not go ahead and move over into that hemithorax by gravity. So you're actually having air trapping down here and keep things in the middle. This can be a helpful thing again, but if somebody's in substantial respiratory distress, it's pretty hard to do. So again, a table presented for you so that you can review about the key discerning features of those airway questions. So a 12-year-old girl is hit by a car while rollerblading. She falls several feet and sustains multiple injuries, including rib, pelvic, and extremity fractures, transported by EMS. Heart rate is 140, respirations are 24, with SATs of 94% on oxygen, 100% oxygen. Initial blood pressure was low, and she received a lot of fluids. Head CT done, normal. On returning from the CT scan, noticed to have sudden duskiness, respiratory distress, cold, clammy extremities. Blood pressure is low. Breath sounds are poorly heard over the right hemithorax. So your first step in managing this child is to do what? Initiate 100% via non-rebreather, intubate the patient, obtain a stat chest x-ray, immediate needle decompression of the right pleural cavity, and call for an urgent surgical consult for chest tube. Okay, you need to be, this is a common PAL scenario, so of course everybody's going to do very well in this. What I placed this in here for was that there's obviously a cumulative gas in the pleural space, between the parietal and visceral pleura. It's tension when the pressure in that space is greater than atmospheric pressure. But one of the important things to remember is that in your neonates, about 1% of patients can have a spontaneous asymptomatic pneumothorax, and it can grow over time. So it's really not just for that trauma case, but really for the neonatology case. And that any barotrauma, such as overvigorous bagging, even if a child's not been intubated, can certainly lead to this in a delivery room setting. Of course, penetrating injury is kind of a no-brainer. So the management is based on the size of the pneumothorax, the extent of the respiratory deterioration, and cardiorespiratory decompensation. Smaller pneumothoraces, however, can happen in patients with chronic disease, such as in this patient with cystic fibrosis and chronic lung disease, and you have to look at the apices. If you have a patient who's not doing very well, or actually the film is taken in a recumbent position, often you're not going to see the apical because the air is going to be anterior and you're going to be shooting through a chest which the lung is actually pressed up against the apex of the hemithorax, and you're going to be shooting through, not across the pneumothorax. So it's important to know the position of in which your chest films are obtained. In the tension pneumothorax, as in this case, the hyperresonance of the affected hemithorax, you have decreased or absent breath sounds, tracheal deviation, hypoxemia, hypotension, as you all got for the scenario. So you assess fatigue, respiratory failure, and this is management of respiratory distress. So the first order business is provide supplemental oxygen, If you can assess for wheezing or bronchospasm, that's acute. You may suspect foreign body aspiration by history. You assess the fatigue and the respiratory failure. Is this an indication, is this child or older or infant getting tired out, looking like there may be a CO2 retaining, and this would be intubation. And in your already intubated patient, of course, you have your, again, going back to your PALS, your DOPE, your dislodgement, your obstruction of the endotracheal tube, your help me. Sorry? Yeah, pneumothorax, yeah, just the scenario, and then other stuff here. The acute respiratory decompensation, you have to suspect air leak. So question number 4, a healthy 10-year-old soccer player has a history of wheezing with respiratory infections, especially in winter. He uses inhaled albuterol with relief. He has frequent sneezing, nasal congestion, and seasonal allergic rhinitis symptoms. His father notes that he coughs while running and playing baseball and is visibly short of breath. He coughs at night, but this doesn't really awaken him much from sleep. You decide to do his evaluation with spirometry, pre and post bronchodilator, and oxygenation. What's the most important? Oxygenation, diffusing capacity of the lungs, expiratory flow rates and volumes, maximal minute ventilation, exercise capacity. The PFT assesses which of these: total lung capacity, vital capacity, residual volume, and air trapping, secondary to small airway obstruction. So this is the question. All right, good. A lot of people said 5, which really, with the spirometry, you're not going to be able to determine total lung capacity or vital capacity, nor residual volume. You may be able to determine air trapping. So spirometry really only does expiratory flow rates and volumes. And you'll almost invariably will get a very simple, what I would expect, a very simple flow volume loop. I doubt you're going to get a full, with lung volumes as well. But the flow volume curve measures flow rates in asthma and other obstructive conditions. So the patient starts here, takes a really deep breath in, and then has a maximal expiratory flow rate. Does a blast air out until they're empty, lungs are empty, and then they go ahead and take another inspiration again. And so what you find is that you have peak expiratory flow, you have a forced vital capacity, the forced expiratory volume in the first second, which you should be able to empty 80%, just know the number, 80% of your vital capacity out in the first second, and your FEF 2575, which measures more of the small airways, and this is expressed in pediatrics anyway as a % predicted. This is a normal flow volume loop, but they're very characteristic patterns in restrictive and obstructive disease. And this would be kind of the quintessential curves you may find here. So this is an obstructive pattern with a concave flow volume loop, or scooping, if you will. There's a force, so basically you're going to have a lower FEV1 with a lower FEV1 FVC ratio. So your capacity is relatively normal and preserved, but the amount of air that you can get out in the first second is decreased. So if you have a lower FEV1 FVC ratio. Whereas in the restrictive pattern, you have a normal shaped loop, it's just smaller. Okay, so you have a normal shaped loop and both FVC and FEV1 are both decreased, so you have a normal ratio. And this would help determine or differentiate the restrictive from obstructive disease. The mixed pattern I can't imagine, but often we'll see a concave loop. There may be smaller loop overall, but I think it's going to be fairly straightforward if you see one of these, and I think you'd probably see the spirometry. And here's another table just so that you can review just about what are obstructive, restrictive patterns, and mixed. So talking about asthma, we certainly would take up several hours of talking about asthma and all the guidelines. The 444 pages need to be reviewed from beginning to end of the NAEPP guidelines. I'm teasing. So you have to take into account the variability of the asthma symptoms. You have to consider the severity when initiating treatment. There are some very helpful tables that you probably use in practice, but if you don't, I would just suggest that you download this and clip a couple of pages out of here, which could be very, very helpful for your practice on a day-to-day basis. You need to, so the current guidelines monitor levels of current impairment and future risk. Inhaled steroids are the preferred therapy across all age groups with leukotriene modulators as the adjunctive therapy. and step therapy, either with long-acting beta agonist or other adjunctive agents considered along. So this is talking about severity, asthma severity in children 5 to 11, and this is one of the tables from the guidelines. And I wanted to call so severity is when you are not currently taking any controller medications. So if you can drill back and go ahead and find out what their severity is, or if they're not adherent at all to the controller medicines they previously prescribed, this is what determines severity. And basically anybody so it's mild, moderate, and severe persistent, and then intermittent. And they took out the mild intermittent because many patients with intermittent can have very significant symptoms. But the frequency of symptoms may, if you have, again, rules of 2, if you have less than 2 days a week with symptoms, less than 2 times a month with nocturnal awakening, and you're actually, the other 2 is use of more than 2 beta agonist canisters per year, this would say that you're in a persistent category, not an intermittent category. And so that the risk here of the exacerbations in requiring oral systemic steroids, so what you've got here is you've got more than two courses of oral corticosteroids in a year's period of time. So this is really very commonly seen with, I think, a lot of children who are really not being pushed to be on controller medications. And I think the risk needs to be included in this. And so with intermittent, the treatment is just beta agonist PRN, but any of the persistent require controller medications, beginning typically with low-dose inhaled steroids, and then stepping up accordingly. And then the step-ups are very well, and the therapies are not going to be asked on the boards, but I think you need to kind of know the differentials here in terms of some of the terminology that is used, and the terminology itself maybe find its way into a question. So question 5, a 9-month-old Caucasian has a daily cough since birth. Cough is worse with URIs. He's active, feeds well. He spits up frequently, but is playful, not distressed. He's had colic with abdominal bloating and frequent loose stools. I'm leading you down a primrose path. Weight gain has been slow. Weight's below the 5th with length at the 25th. There's a family history of asthma and GERD. So your clinical diagnosis at this point, before further investigations, is mild persistent asthma, CF, GER, swallowing dysfunction with microaspiration, and bilateral vocal cord palsy. Okay, CF, of course, especially with the abdominal bloating and nasty stools. So the couple of things you'll need to know, most of these are highlighted in yellow. Obviously autosomal recessive, it's in 1 in 3,300 affected, 1 in 25 carrier. More than 1,000 known, it's actually 1,800, that's a misprint, 1,800 known mutations. The most common mutation being delta F508, which is the deletion of phenylalanine. 85 to 90% of these delta F508s are pancreatic insufficient. And the diagnostic test, the first diagnostic test is you need a high index of suspicion. Not everybody, I mean, this is really a slide really from past generation, because really we don't see a lot of kids coming in with malnutrition and bloated bellies and absolutely abnormal stools, but you see a much milder form. Everybody is screened now. All 50 states are screening, for newborn screening, but still the gold standard remains the sweat test with a high sweat chloride level and the newborn screen demonstrating elevated IRT. So the clinical hallmarks obviously are the chronic respiratory disease, pancreatic insufficiency in about 2/3 to 3/4, failure to thrive, elevation of sweat chloride, and obstructive vasospasmia. The CFTR, which is has 2 membrane spanning domains and nucleotide binding folds, and then blockage of the chloride channel or chloride through the channel. And it is not just a lung disease, of course, or even a GI disease alone, as Dr. Melton alluded to. Chronic sinusitis or nasal polyposis raises the concern. And what you're going to be picking up in the office and what they may be kind of pushing you on board questions is some of the milder forms, the milder genotypes, and phenotypically mild expression of these milder genotypes. You can have meconium ileus, but only in about 15 to 20% of patients. Of course, you have the chronic bronchitis, the cor pulmonale, malabsorption, et cetera, and 95% of males with obstructive vasospasmia. Rectal prolapse is also something that often can find its way into a question on the boards. And so these are pictures from, ancient history here, but we don't usually see such nasty stools, except in kids who've already been diagnosed in the hospital. Rectal prolapse is something which can be a very significant presenting symptom in patients who are milder phenotype, milder and actually may escape newborn screen, and you don't see much malnutrition with the pitting edema here. But abnormal viscous sputum is the characteristic. Anybody who's trained at a CF center or has dealt with CF knows this. The respiratory microbiology, I think it would be helpful to know that by about age 8 to 10 years, about 80% of patients are colonized with Pseudomonas. So if you're given a scenario with somebody who's got H-flu or strep or staph in the younger age groups, it doesn't exclude that. Pseudomonas really is not that prevalent early in life. The factors predisposing to the respiratory infection are the reduced mucociliary clearance due to the decreased airway surface liquid. That liquid phase, there are two phases of airway lining fluid, a gel phase and a liquid phase. The liquid phase, because of hyperabsorption of chlorides, sodium goes along with that and water goes along with the sodium. So there's that sol layer or the liquid layer is desiccated, and instead of the cilia being able to just get their tips into the gel layer and pushing mucus out, the cilia are crushed and it's like rowing in jello. And so what happens is you have decreased ciliary clearance, you have decreased airway surface pH, which alters your innate defense. You have a vigorous recruitment of neutrophils into the endobronchial space, which causes lots of proteases and elastases there, which exceeds the body's capacity to have the antiproteases there. You have an altered pattern recognition of the mechanisms for the pathogens. So those exaggerated proteases there cleave the ability of the neutrophils that are there in abundance to bind to the Pseudomonas and other organisms and do their opsonophagocytosis. So you have a kind of unrelenting infection paralleled by unrelenting inflammatory response. And what occurs then is that the neutrophils, which are terminally apoptotic cells and have a lifespan of only 6 to 8 hours outside the circulation, they dump all their toxic oxygen things that should be destroying the bacteria intracellularly. They release those chemicals without having extracellularly as the neutrophils die, and they result in bronchiectatic changes. And so the signs and symptoms, increased cough, weight loss, decreased FEV1, radiographic findings, the pulmonary exacerbations are pretty commonly understood. So the pulmonary function test shows a decline in FEV1. There's hyperinflation infiltrates on radiology, and there may be a role for bronchoscopy and bronchoalveolar lavage to be able to identify organisms which are not the classic organisms such as Mycoplasma avium intracellulare, all the other non-atypicals, to go ahead and which require an entirely different set of treatments than the standard cephalosporin aminoglycoside combinations. So with mild disease, you see hyperinflation with increased markings, and you see bronchiectatic changes with more advanced disease. I don't think anybody's going to really talk, but there may be questions now with ivacaftor and lumacaftor that there's kind of 5 classes of abnormalities of CFTR mutations. So class 1 through 5, and they're based on the severe, what the block or decrease in production or effectiveness of the CFTR. So the most severe mutations are the 508 deletion here, which are a block in processing. You have milder mutations such as R117H, which is altered conductance. So these medications that are now available, ivacaftor or lumacaftor, are having very great success. The median lifespan right now is around 40 years old for CF. I'm sure that's not going to be there because there's quite a variety, of course. But these medications that are CFTR correctors or blockers or conductance fixers, if you will, have great potential for extending the life of our patients quite significantly. And we have a lot of patients who are demonstrating nationally quite an improvement in their clinical course. So the potentiators work to increase the activity. The correctors work to move the mutant CFTR protein to the surface of the cell, and their read-through agents work by replacing the stop codons to promote a full-length mRNA. So there are a lot of targets for this, although obviously the holy grail is gene therapy. So the high-yield factors, or the high-yield facts for the boards. Newborn screening. Screens with serum IRT and genetic mutation screen. So positive newborn screen you need to get a gold standard sweat test. The PFTs may show us obstructive defect, but that's obviously not pertinent to somebody who's in the infant or toddler range, really. There may be a question on a patient who presents with hyponatremic, hypochloremic metabolic alkalosis. That would be something that would be CF until proven otherwise. Additional questions on the boards? Newborn screening is conducted in the United States, now all states. Test for elevation in sweat chloride, IRT, fecal elastase, genetic mutations of CF, including Delta F508. So I already gave you the answer, so we can just let this go. It's the IRT, of course. And in order to definitively diagnose and inform parents that their child has CF, what do you need? A positive newborn screen and at least one parent who is a known carrier, a positive newborn screen in a child with meconiamelia, steatorrhea, and elevated fecal elastase, elevated sweat chloride, or genetic testing positive for 2 mutations for CF. Okay, so the sweat chloride, despite the fact that you may have 2 positive mutations for CF that are known mutations, they may not be really significantly disease-causing mutations. So you may be able to diagnose it, but you're going to be able to miss it for a while, certainly before, and it may be a much later presentation, but the gold standard would be the elevated sweat chloride test. The most common reason for a false negative sweat test is too young, patient weight less than 10 pounds, acute illness with dehydration, inadequate volume of sweat, lab error, and chloride estimation. Okay, inadequate collection. And of course, A and B would lead to D in that case. All those would lead to that, but the correct answer would be inadequate volume. It's very difficult to be able to get adequate amount of sweat collected on a former preemie or neonate. And this is an algorithm, screening algorithm, which you may review a little bit about when a sweat test and when to refer to a CF center. So again, sweat test, the normal, the positive is in the textbooks is over 60. We've seen people with positive or with disease with lower, but the answer for the boards would be over 60 milliequivalents per liter. False positive sweat test, again, malnutrition, adrenal insufficiency, and false negative with the edema with hyperproteinemia, more commonly inadequate collection. So the major cause is respiratory infections. We won't go over there. Dr. Melton already stole my thunder here about if you see nasal polyposis, you need to go ahead and think of CF and get a sweat test. So we're going to skip over this so we can get to some of the others here. Okay, so 18-year-old girl has chronic cough since childhood, frequent ear and sinus infections. She uses Advair for twice daily, singular at bedtime, and albuterol is needed. She has a daily cough, productive of sputum. She's able to tolerate moderate activity, but reports shortness of breath. She denies smoking or use of recreational drugs. You review her x-ray, and this is what you see. Your diagnosis is what? Bronchiectasis, acute asthma, CF, cartagenars, common variable immunodeficiency. Okay, yes, cartagenar syndrome, but that's when you can identify situs inversus totalis. 50% of people do not have situs inversus totalis. So if you have the cardiothomic silhouette on the correct side, it still could be cartagenars. And if you have that history, it's very reasonable to consider pulmonary primary ciliary dyskinesia one of these ciliary dyskinesia genotypes. And the best way now to go ahead and identify them is by nasal nitric oxide, and even better by referring for genetic testing, because there are many now, I think 30 genotypes which cause different mutations. You'll not need to know any of them, but you do not, if you see something that gives this scenario, you need to at least consider one of the correct possibilities may be cartagenars, even if you don't see situs inversus totalis. So regular bronchiectasis, there are 2 types, saccular and cystic versus cylindrical or tubular. There's infection obstructing mucostasis, and pathogen colonization, very similar to CF. But the causes also may be immune deficiencies, recurrent infections, cartagenars, as we said. There may be allergic bronchopulmonary aspergillosis, which is leading to obstruction by accumulation of aspergillomas there in the airway. The patients can have bronchial stenosis, obstruction, airway compression. So there are multiple forms, and you don't just say CF when you're thinking of some of this. So the chronic productive cough, you need to consider this, mucus impaction, this tram tracking sign, which is out here, going out here, and the signet ring sign, so that on high resolution CT, so that the adjacent airway is larger, should be larger than the adjacent blood vessel, and in this case, this airway is no larger than the adjacent blood vessel. So that's a signet ring, and this tram tracking sign seen in the contralateral side here is kind of a classic picture of bronchiectasis. So airway clearance, aggressive antibiotic use, regular care, serial pulmonary function testing. So quickly, a girl with trisomy 21 with asthma is on inhaled steroids. She's adherent. She's not very physically active, has gained 15 pounds recently. She's been doing well in special ed until recently. She's been irritable in class with poor attention span, not been learning well. She's always had snoring, but this has increased in recent months. Your priority in her management at this time is refer her for a sleep study, increase inhaled asthma medicines, referral for screening and evaluation for ADHD, nutritional counseling for weight gain, and repeat skin testing for environmental triggers. Intensify treatment for allergic rhinitis and nasal obstruction causing snoring. Okay, yeah, refer for sleep study, but you also want to do probably nutrition counseling at the same time. But if the sleep disordered breathing is huge, with kids who have airway issues or have hypotonia of some form because of neuromuscular weakness or because of craniofacial abnormalities, clearly need to be considered for, especially with school performance changing from what their prior baseline had been. Recent weight gain, choking, pauses in breathing, learning difficulties are really kind of classic tip-offs. Bruxism also can be a tip-off. So primary obstructive sleep apnea syndrome is children 2 to 6 years, usually with adenotonsillar hypertrophy if they don't have some other facial dysmorphism. The secondary being craniofacial abnormalities and neurologic disorders. This is where these come in greater amounts later in life. But the polysomnography is the gold standard. And the hypoxemia, the physical consequences of hypoxemia, that is room air saturation is less than 90%, or hypoventilation resulting in hypercarbia, right heart strain, ultimately develops cor pulmonale. The sleep fragmentation, ultrasleep architecture, you're not going to find this on an oximetry study, an overnight oximetry study. The risk factors, again, adenotonsillar hypertrophy, obesity, craniofacial abnormalities, and hugely in trisomy 21, where they have a large tongue proportionate to their oropharyngeal diameter. They have hypotonia as well. And so consideration for a CPAP or BiPAP is very much a part of therapy for them. Difficult to get them to do it, but it takes time. And a lot of perseverance on the parents' part and the clinician's part as well. A 12-year-old football player had an ankle fracture last season, prevented him from playing. He's anxious to get back. He has exercise-induced asthma and seasonal allergies and uses albuterol before sport with benefit. He now presents with shortness of breath when playing and reduced exercise tolerance. He finds it hard to breathe, reports palpitations, severe chest pain, and has stopped playing until symptoms subside. He's very anxious because it's affected his game and performance on the team. Of his conditions below, the most likely diagnosis at this time: inadequately controlled asthma, chronic sinusitis, suboptimal conditioning, vocal cord dysfunction, undiagnosed cardiac condition unmasked during exercise. Okay, vocal cord dysfunction. I think one of the things you may find, certainly deconditioning can be there, but this is somebody who's pretty type A and is probably driven to get back into sports here. This is where the vocal cords paradoxically close during inspiratory phase of respiration. They produce an audible wheeze and stridor. I've seen children actually in intensive care units and intubated for wheezing that's unresponsive to albuterol, but is responsive to biofeedback. He does not respond to adequate asthma therapy. That's a tip-off. He has theoretically normal spirometry at baseline, But what's going on really is that you have this when you get a PFT. So instead of having the normal inspiratory limb of the flow volume curve and a normal expiratory limb, you have a normal expiratory limb and a very attenuated, truncated, flattened inspiratory curve. And so this is when the patient is going like this as they're taking a breath in, and they feel that their shortness of breath, like their asthma is going out of control, but because they're driven to succeed, they're really often somebody's been playing on an elite team, and now they're having problems. It's probably with acute chest pain and often a description that there's retrosternal pain. I think you really need to consider this entity. This might be something which you would see in this flow volume curve on a board test, because it's pretty characteristic and found in a lot of textbooks now. The 4-year-old, let's see, we can skip through this. Okay, pneumonia, etiology according to age. Neonate, group B strep, E. coli and other fecal coliforms, chlamydia trachomatis. Young infant, perinatally acquired pathogens such as listeria, community-acquired strep, pneumo, staph, and Haemophilus influenza. Younger children, up to 5, viral, RSV, influenza, adenovirus, other, community-acquired other infections. And older children, the atypicals, over 5, the atypicals such as mycoplasma, community-acquired things with the pneumococcus are much more commonplace. The pneumococcal classically presents with fever, chills, rusty sputum. The radiologic is in a lobar pattern with their bronchograms. The x-rays lag behind the clinical findings, and you should do, if you have somebody with a lobar infiltrate, you should do follow-up x-ray 4 weeks to 6 weeks after the acute episode's resolved to demonstrate resolution, so that you can show that it's not something like a pulmonary sequestration that is, an infiltrate that may have been there because he may have been ill, but it really is a vascular and a structural abnormality of a part of the lung. Viral pneumonia, the cause, the majority of pneumonia is difficult to distinguish. Usually there's a prodrome of URI, progresses to cough, tachypnea, malaise, lethargy, interstitial markings. Again, interstitial pattern that you've all seen. And the walking, the atypical means it didn't respond to the usual antibiotics, mycoplasma, chlamydia, bilateral interstitial infiltrates, patchy consolidation, and 20%, even more perhaps, of patients with effusion. So if you have effusion, you must include mycoplasma in your differential as well. Okay, and that's it. Only a minute and 45 seconds over. There you go. You're back on track.